first step of the procedure is inspection of the joint. ACL looking fine, meniscus, and then we have a punched out cartilage defect full thickness at the lateral femoral condyle. Second step of the procedure would be some debridement of the capsule to have enough space for implantation of the minced cartilage AutoCart procedure, which will be performed under dry conditions. So for that you need a slight debridement of the capsule to have enough space. During the second step, you connect your GraftNet device to your shaver, and then you take a 3.5 or 3.8 soft tissue shaver to collect cartilage from the vital edges. For that, it is very important to have a good suction device, and then you apply gentle pressure to the cartilage edges, and you can see here actually how the shaver is properly taking away healthy, regional correct cartilage from your edges of your defect. By that, you're very effectively stabilizing the edges to have a stable rim, but at the same time you're activating the edges or the cartilage at the edges. So finally you will be transplanting activated cartilage to activated edges. And by that, it is easy to harvest enough cartilage for further transplantation. And you can always monitor that by the translucent GraftNet tissue collector device. So for perfect harvest, it is very important not always to harvest only in flexion, because to reach at the proximal parts of the defect, it is very important also to collect in full or close to extension. Beware not to collect synovial or fat tissue from the capsule, which is being sucked into your shaver device during collection. Final checkup of the joint, and then you stop the water influx. And then with your shaver device, it is very easy to dry out the joint, just like that. For optimal drying out of the joint, you can take a regular tissue swab, go gentle into the joint, and then dry out the lesion to have perfectly dry conditions. And then you actually can take the same tissue swab to put it under or beside the condyle. You can take your probing hook and check for recording conditions the size of the lesion. So this would be actually a very small lesion, approximately 1.5 times 1 centimeter. So in the next step, you take your dried out GraftNet device, you open it up gently, and then you have your plunger. You take out the plunger gently with your collected cartilage and put it in your tissue basket. In the next step, you take your ACP syringe and put some drops of ACP to your collected cartilage. Just a little bit. And directly after, you take an anatomic forceps and mix it up with the ACP. And you can see here absolutely that you have nice small chips perfectly for transplantation. So the next step of the procedure would be filling up your application cannula with your chips that are currently sitting in the ACP. For that, you disconnect it and gently take your chips and go step by step, putting these in the cannula. And then you can easily take your obturator and gently push the cartilage in front. When all your cartilage chips are in the application cannula, you gently push forward your obturator to be in a perfect position for subsequent implantation of the chips. You're coming in with your loaded application cannula, and for that you always need a 3-portal approach, one for the camera, one for drying out the joint and for capsular distension, and the third one for your chips. And then again you go gently into the joint, and you can see here the chips are sitting in place, and by gentle pressure you can easily apply the chips to the lesion. Finally, to take the application cannula, and because of the nice design, it is easy to flatten out the chips across the lesion and fill up the lesion not to 100% height, but only to 80 to 90%. When the chips are divided across the lesion, you're coming in with your thrombin coming from the Thrombinator, again gently coming through your extra portal, and then it is recommended to go above the lesion and gently drip your thrombin across the defect. And within the defect, your thrombin will be connecting to the ACP, and it will build autologous fibrin just across the lesion to keep the chips in place. So for the final step of the procedure, you're coming in with your autologous fibrin, which has been produced externally by mixing ACP with autologous thrombin in a 1-to-1 fashion. Again, you're coming in gently via your third extra portal, gently go above your lesion, and then gently drip the fibrin as your final layer over the defect. So this again is catching up within the joint, clotting, and then should have a good initial stability for early rehabilitation. Now you have to gently remove your tissue swab. The capsule is coming back. You have to remove it from the joint. And to be sure you have no delamination and a good coverage of your lesion, you perform full extension flexion maneuvers in the way of cycling the joint, and then you can see here that the product is staying very safely in place with the help of the fibrin glue, with a perfect coverage of the lesion. And no delamination, even though touching the meniscus, tibia, capsule, and your Hoffer fat pad. In that case, you don't even require a drainage, and you can easily go for early rehabilitation.